Hello everyone, welcome to the another episode of Next Saviours Essential Question Series NEET PG 2025. Today we are going to have a discussion on opportunistic infections in the HIV, a step-by-step approach in making the diagnosis. So you see, this is the sample question. The first thing is they are going to provide is either confirmation of that the patient is suffering from HIV or a predisposing factor like unprotected sexual intercourse or history of intravenous drug abuse. Now the patient presents with fever, dry cough, and progressive shortness of breath. Now for that specific disease, they are going to provide you the clinical findings. And the second thing that they will be giving is the CD4 count, which is 150 cells per microliter in this case. And then they will be providing you the classic X-ray findings or the clinical findings on the basis of which you will jump onto the diagnosis. So there are three contents in every question. Like one is the confirmation of the HIV, two is the CD4 count, and three is the specific finding for the disease. Similarly, if you look at another example, like in this case over here, a 40-year-old HIV positive male. Now here they have provided you that patient is HIV positive. Now here again CD4 count of 400 cells per microliter, presents with a specific finding for certain disease, and then they will ask you what is the disease the patient is suffering from. Now, what is the importance of this CD4? As HIV progresses, CD4 count declines, leading to increased vulnerability to opportunistic infections or the malignancies or the AIDS related complications. Why is it important for us to discuss? Because certain infections occurs at a specific CD4 level. So this is exactly what we are going to talk about, making CD4 count a useful tool for the clinical risk assessment and ultimately the diagnosis. Now, if in a question, if the CD4 count is given less than 500 cells per microliter, then think of these infections like oral candidiasis, Kaposi sarcoma, oral hairy leukoplakia, or the pulmonary tuberculosis. Although these infections might happen at any CD4 count, all of you are aware of the causative organisms and how they will be provided to you in the question. Like there is going to be a white curd-like plaques in the oral cavity which can be scraped off, a feature of oral candidiasis. On the other hand, if there is a white but it is non-scrapable plaque on the lateral aspect of the tongue, most commonly which is provided, is the feature of the oral hairy leukoplakia caused by Epstein-Barr virus. And if there is a purple red skin lesion, then it is a feature of Kaposi sarcoma caused by human herpes virus 8. So on the basis of these specific findings, you can ultimately jump to the diagnosis. Then, if the CD4 count is given of less than 200 cells per microliter, then think of pneumocystis pneumonia, progressive multifocal leukoencephalopathy, or cryptosporidiosis. All of you know the causative organisms and how they are going to be provided in the question. Like for sporidiosis, there will be chronic watery diarrhea. For a progressive neurological deficit, the white matter lesions on the MRI is a feature of progressive multifocal leukoencephalopathy. And as we have already seen in the question before, like there is going to be a diffuse infiltrates on the chest X-ray along with the fever, dry cough, and hypoxia. These are the features of the pneumocystis pneumonia. Once you have identified it to be pneumocystis or progressive multifocal leukoencephalopathy, then you have to also learn about the management of individual conditions. Like, for example, if I say that in case of pneumocystis pneumonia, the treatment of choice is, or the first line management is trimethoprim sulfamethoxazole. But what in those cases where the patient is suffering from the sulfa drug allergy? Then in that case, what is the role of Dapsone? What is the role of pentamidine? What is the role of clindamycin? Then, so these are the things that you also have to go through. We are restricting ourselves for the purpose of identification. Once you have identified, you also have to learn the management by heart. Now, in case if the CD cell count is given less than 100 cells per microliter, then the disease which probably could be asked in the question are toxoplasmosis, cryptococcal meningitis, and disseminated histoplasmosis. Now, you already are aware of the fact that disseminated histoplasmosis, the clinical features would be provided in the form of fever, hepatosplenomegaly, pancytopenia, lung infiltrates. While in case of cryptococcal meningitis, there is going to be a feature of meningitis. And for toxoplasmosis, they used to ask it very commonly, like there is going to be a multiple ring enhancing CNS lesions on the MRI, along with the clinical features of the seizures, headache. So these are the things which will be provided to you on the basis of which you have to make the diagnosis of the toxoplasmosis. And if the CD4 count is less than 50 cells per microliter, now in that case, you have to think of the CMV retinitis, and Mycobacterium avium complex. The clinical features are going to be fever, weight loss, diarrhea, hepatosplenomegaly. While in case of CMV retinitis, they will be providing you a very specific finding where there will be a patient suffering from painless loss of vision along with fundoscopic finding of fluffy retinal lesion with the hemorrhage, also known by the name of pizza pie appearance. You all know that how is it managed, like what is the role of well-gencyclovir for the prophylaxis, what is the role of gencyclovir or foscarnet for the management of this CMV retinitis. So this is something that you have to learn. Similarly, for Mycobacterium avium complex, what is the role of azithromycin in the prophylaxis and how is it treated by clarithromycin or ethambutol? So what I'm suggesting is that it is essentially important for you to remember the treatment for each of the conditions that we have discussed. Now, what is the role of antiretroviral therapy in opportunistic infection management? That means when to start the antiretroviral therapy. Now, you would be saying that the patient is suffering from HIV and because of that, he is suffering from the opportunistic infection. So, immediate ART has to be started? No. You see, immediate ART is not always recommended in patients with active opportunistic infections. So, there are timings which are dependent on specific conditions. And but when I say specific condition, if the patient is suffering from tuberculosis where the CD4 count is more than 50, then the ART has to be initiated 8 weeks after the management of the TB. Why? Because there it reduces the risk of immune reconstitution inflammatory syndrome. Similarly, for cryptococcal meningitis, the ART has to be started 5 weeks of antifungal therapy. Why? Again, because it prevents the IRS and the fatal brain swelling. So it's not always that ART has to be initiated or is recommended to be started immediately. So that is the reason why I'm again repeating the fact that once you have reached the diagnosis, once you have learned about it, it is important for you to remember the management of each. So hope you have understood the session. Thank you very much. Or in order not to miss any update, please join our Telegram group.